is 22 countries, the ones in green, and the ones in yellow are between 5 to 50 cases, which is the most on the continent. We have 5 countries reporting more than 50 to 100 cases every day, and 2 countries are reporting more than 100 cases per day. Then we can look at the case fatality ratio and who is reporting what. 9 countries are less than 1%, to 24, which is the highest in that bracket, 1 to 2.2, 18, 2.2 to 5, and more than 5 is 3 countries. So you can use the colors to see from the map on the left which countries are reporting which case fatality ratios. So we can look at now the total tests across the continent since the outbreak started in February last year. We've done more than 38.1 million tests have been conducted, and the positivity rate is at 10.6, and 9.4 tests have been done per reported case. So that's that for the testing. And then we can look at test per case ratio by country. So still using the colors and the legends to look at the map to see which countries are reporting less than 10 tests per case, and that's about 19 of them. 27 countries are reporting between 10 to 30 tests per case. 7 countries are reporting 31 to 100 tests per case. Another 1 country is reporting more than 100 tests per case. So they can use the legend to look at the maps. And that's all from us. Thank you very much. Over to you, Dr. Iwande.
Fantastic. Thank you, Ezine, for that succinct presentation on COVID-19 status across our continent. On that note, I would like to welcome Professor Shade Ogoshola to talk a bit about IPC considerations for healthcare workers and for general public around COVID vaccination rollout. Over to you, Prof.
Thank you very much. Let me having some problems sharing my screen. I don't know what's happening. Sorry, I'm having some difficulty. It's very unusual. Okay.
Hi, Prof. Are you having technical challenges? Okay, fantastic. We can see.
Yes, I was. It's done now.
Great.
Thank you. Thank you. Good morning, everybody. And this morning, I'll be talking about IPC measures for COVID-19 vaccination rollout. Just to quote the WHO about the importance of immunization and vaccination. So it's not new because we're having a lot of vaccine hesitancy, but it's something we've been using, and we know that it averts about 2 to 3 million deaths a year. So today I'll be talking about the COVID-19 vaccines, a little bit about how they work, the risk associated with vaccination activities, preparing the facility for safe vaccination, and then IPC measures during the vaccination process. And then I will answer about 2 or 3 questions that have been buzzing in the internet. So before I go on, I'd just like a question from participants. Which part of the chain of transmission do we think that the vaccines break? You can put that in the chat. Wendy, have they answered? Thank you. Sorry. So it protects the susceptible host. That's the main part that immunizations do. So let me go on that. So on the 31st of December, 2020, Pfizer-BioNTech was the first vaccine to be given emergency validation by WHO, which is almost an exact 1 year from the first call of when we first heard about the outbreak in China. By February 18, there were 7 vaccine candidates that had been rolled out and 200 vaccine candidates in the pipeline, with more than 60 in clinical development. Today, the most common ones that we hear about, Pfizer-BioNTech, Moderna, AstraZeneca, Sputnik, Sinopharm, Sinovac, and the Johnson & Johnson. And the African Union, through the Africa CDC, have collaborated with WHO and other partners to pool resources and the requirements to improve access to vaccines on the African continent through COVAX. So what are vaccines? They consist of a dead or attenuated form or part of a pathogen causing a specific disease that, when recognized by lymphocytes of our immune system, trigger a response that results in the production of antibodies. I just wanted to share with us, because that also speaks to when the immune system is triggered, when the body first sees a pathogen, the body starts to gear up. It moves all the lymphocytes and all its arsenal to the point to the pathogen, to understand that pathogen and produce cells that will recognize it when it comes again. So that's the primary response, and it's pretty slow. So when the first exposure occurs here, you have this primary response that's not so big. But the important thing about that primary response is that it develops memory cells, cells that have seen this pathogen before, and when it comes again, can react quickly. So the secondary response occurs when the pathogen comes again, or when we give the vaccine a second time. And this time, the body reacts faster. Not only does it react faster, it produces a bigger, more robust response to the pathogen. This is what we call the anamnestic reaction. We have a primary response that takes a little while, it's not so robust, and a secondary response, which is a boost that is stronger and more robust. And when we talk about herd immunity, it's because that's said a lot, is that we're looking for a way to ensure that when there's an infected person is in a community, he will find very few people that are susceptible. So essentially what we're trying to do is build the general population resistance to the pathogen. So if you have this person here, and only a few people are vaccinated, it means all these people can get infected. So when that person is in this kind of community, you can see very quickly many people will be infected. However, if you have an infected person and many people are vaccinated, the chances of coming across an an unvaccinated person is very slim. So even though there are more people here that have not been vaccinated, he only has access to maybe 1 or 2. And you see, at the end of the day, using the probability that an infected person will come in contact with an uninfected person or a susceptible person. So these are the COVID-19 vaccines. You have, and these are their types. We have 2 of them that are messenger RNA. They're 2 doses, 95% efficacy, and they have, but they require storage levels. So Pfizer-BioNTech minus 70 degrees centigrade, even though Moderna can do minus 20 degrees for up to 6 months. Oxford AstraZeneca, Johnson & Johnson, Gamaleya, Sinopharm, Sinovac can all be put in the fridge. Oxford AstraZeneca, Johnson & Johnson, and Gamaleya are viral vector, they're DNA vaccines. Only Johnson & Johnson is 1 dose. Sinopharm and Sinovac, which are from China, are inactivated viruses. So how do they work? And I thought it was important to put this here. The virus vector ones, which are the DNA virus, essentially what is done is that they take a virus and make it inert. So essentially sort of gouge it out and put in a coronavirus DNA that codes for the spike protein. And this is injected. And this enters into the cell and produces the messenger RNA, which goes on to the ribosomal RNA and produces the spike protein, which is what our immune system reacts to. And this spike protein is put out here and the body reacts to it. Now, the messenger RNA vaccine, on the other hand, doesn't go through all that step. It actually just produces the messenger RNA, which comes into the cell. That is recognized by into the ribosomal RNA, where proteins are produced and the immune system, the spike proteins are produced and the immune system can react to it. The thing about RNA is that it is very easily degraded. So it is actually, so over time, it's actually degraded and will be eliminated from the cell. Then we have the ones that contain the killed vaccine or weakened vaccine. That's a whole virus, but it has been either killed using a chemical or made weaker. We don't have any of the attenuated ones here. That's the weakened ones. So once the whole virus that cannot multiply and that is dead, essentially, but has all the antigens, is injected into the body recognizes all these, I mean, the body mounts an immune reaction against the proteins that are there and all the various antigens, so that next time when you get a second boost, the body reacts again, the second reaction. So this is how they work in a nutshell. Now, what are the risks for infection at the vaccination site? First of all, let me say that the risk for infection by giving an intramuscular injection is minimal. Most of the risk comes from the fact that there'll be many people coming to the site and you really don't know who has COVID or not. So there's still that risk that people can get infected at the vaccination site. And then, of course, so that's the main source of risk for infection. So a lot of what we're doing for IPC is around ensuring that we don't have that kind of transmission of COVID, and also protecting from other infections that can occur from injections and so on. So the key principles for COVID-19 are ensuring standard precautions, ensuring transmission-based precautions, ensuring that healthcare workers are trained to be able to give the vaccination safely, that you have a good, clean, well-ventilated, spacious environment, and that the country has national guidelines and protocols to ensure that all this happens within a framework. So essentially, what we seek to do at these vaccination sites, using the hierarchy of controls, is one, to eliminate the possibility of COVID going into the vaccination site. And I'll explain how that will happen by providing the engineering and environmental controls to reduce worker contact with the pathogen, to have the right administrative controls, work policies and procedures that will prevent pathogen exposure, and of course PPE for personal protection of workers and prevent their exposure to the virus. Now, in applying all this, we have two phases of the IPC application for vaccine deployment. And the two phases are: one, at a stage when you're preparing for this, because this is a massive undertaking and can't just be done in a haphazard way. So all countries have to prepare for it. And the first one is to identify which facilities that you will use to ensure that they're well positioned, they're not too far from people, and that you have enough of them so that you do not have crowds. And then to ensure that the facility is large enough, has good ventilation, has a good layout. And in terms of ventilation, what is preferred is if you can do it outside. Then we would have a lot of and then to ensure that you have adequate wash facilities, because people will be working here from morning for long hours. And one of the things we also look at is the workflow, so that patients are not hitting each other, and so that there will be chaos. So you want a unidirectional workflow, and you want to ensure that wherever you're working, this is ensured. Of course, to ensure that you have adequate supplies and that you have a good supply and chain, you have to have developed your protocols and signages, and then of course, prepared the human resources. And then the second phase is the operational phase. That is when the vaccination actually starts. So the administrative controls during the preparatory phase is to develop screening policies for COVID-19, signs, symptoms of COVID-19 signs and symptoms of staff and individuals that arrive for vaccination, and to have clear exclusion criteria. If these occur, these people should not come in for vaccination. To determine the IPC measures to be taken by people in the vaccination area, such as the type of cleaning and disinfection of the environment, to have appropriate waste management to ensure that sharps are properly taken care of. You have the sharps boxes, to have the type of PPE that will be worn, and hand hygiene, and where this hand hygiene will occur. Then you should also have protocols that speak to mothers that may come with their babies, how the babies will be handled, or mothers that may come with their infants, because you will have people who cannot leave children at home. So things like how the babies should be turned towards the adult while the adult is being vaccinated. Breastfeeding babies can be allowed to continue so that they don't disturb they don't cause chaos within the vaccination site. In addition, to place all these signages in strategic areas, signages that will direct patient flow, how they will move from the entrance to the exit, and remind them about hand hygiene, signages to talk about safe injection practices, the safe use of medical masks and other IPC measures, to develop training materials for healthcare workers and train them before operationalizing what they should do. And you should also have role plays that show that go through how they handle situations that may occur. Patients coming in, if there are some issues at the vaccination sites, how these should also be. And then to develop IEC materials. These are educational and communication materials for the general public on vaccination, on where the locations are, on the eligibility, on prioritization strategy, and to also have questions and answers that address the fears and the fears of the public, and to have IEC materials on COVID-19 symptoms and signs, and to say who should not come for vaccination. For example, if somebody is ill, that's not the time to come for vaccination, because then they pose a high risk to others there. For the training of healthcare workers, the training should include things like standard precautions, hand hygiene, doffing and donning of PPE, injection safety, environmental cleaning, and waste management. There should be training on transmission-based precautions, especially in particular about the masks and the the wearing of masks and the hand hygiene, then screening for COVID-19 symptoms and signs, and then also train them on all the policies and guidelines that have been developed. Still in the preparatory phase, where you're dealing with the environmental and engineering controls, outdoors are preferred because the ventilation is great. But if you do not have outdoors and you have to have indoors, then ventilation, and spaciousness. What you do not want are crowds within the vaccination center. The location should be separate from treatment areas if they're in healthcare facilities. And you should ensure that the space can accommodate the numbers of people that you expect to have with at least 1 meter between them. So if you think that your space can take 10 people with 1 meter between them, that's great. But you should not have more than can be accommodated within the space. And whatever you do concerning ventilation, one big wide open windows, and it should be at least 6 air changes per hour. The vaccinations area should also have clearly marked entry and exit doors or areas, and it should be a one-way traffic flow with people coming in through the entry and going out through the exit. At the entrance of the vaccination, there should be a screening area at the entry points to assess people for COVID-19 symptoms. There should also be at the entry and exit hand hygiene stations, and there should be adequate hand hygiene stations in picture. The vaccine stations where vaccination are occurring should be at least 1 meter apart. Surfaces should be easy to clean, and there should be adequate waste bins and sharp boxes at each station. They should be as close within one arm's length of those vaccinating. These are just some pictures of vaccination stations. So you have people vaccinated, you have this is here you have for COVID-19, this is outdoors. Again, here's another place that's outdoors. So, operational phase. One thing you do not want is to have crowds. So as much as possible, people should come by appointment. And when they do come, if you have waiting areas, those waiting areas should ensure that they are separated by at least 1 meter. If indoors, ensure the windows are open to allow for cross ventilation. Where there is a queue, patients should queue with 2 meters between persons. But where this is not feasible, the distance should be at least 1 meter. You should mark the floor with tape, marker, or chalk, at least 1 meter apart to assist with the physical distancing. Then have hand wash stations or alcohol hand rub at the entrance and exit points of the vaccination area and also in the waiting area. For hand hygiene in the operational phase, all staff should wash their hands with soap and water on arrival at the start of the shift and when leaving. Staff should wash their hands or use an alcohol hand rub before seeing each patient. I'm going to show you this because if you think of the 5 moments of hand hygiene, you will actually take care of moment 1 and moment 2 by just doing 1 hand hygiene before seeing every patient, because that would take care of moment 1 before seeing a patient, and it would also be moment 2 before an aseptic procedure. You do a hand hygiene. So it will be before seeing a patient and before doing an aseptic procedure. And as soon as he leaves, you're going to do your hand hygiene again, which will be before seeing the next patient and so on. So if you think about it, a patient walks in and the person vaccinating does the hand hygiene. The person exposes the arm, the vaccinator cleans it, disinfects the skin at the injection site, picks up the pre-prepared single-use material for vaccination, performs the injection, discards the needle into the sharps disposal container on the table, then applies adhesive bandage to the injection site, and then the patient leaves the room. The vaccinator writes a note on a sheet of paper, then and another person walks in, the vaccinator does a hand hygiene. And so just by doing that one, you're covering two moments for hand hygiene. PPE, you select PPE based on risk assessment. And it is, which could be mask, eye protection, gloves, and gowns. But staff administering the vaccine should wear a medical mask, and the patient should wear a medical or non-mask. For screening activities and vaccine administration, only a mask is indicated, since there is no splash or body fluid exposure risk during an intramuscular injection. So you don't need to use gloves. You just need to do your hand hygiene. However, yes, so gloves are not indicated for intramuscular or intradermic injections. Single-use gloves are indicated if there is any skin breakdown, and when they're used, hand hygiene will still be done between each vaccine administration. Do not use alcohol-based hand rubs on gloved hands. The PPE for healthcare workers. This is from the Africa CDC site. Healthcare workers and community healthcare workers. For the preliminary screening, not involving direct contact prior to vaccine administration, a medical mask, you could use an eye protection, but really what you need is a medical mask. Healthcare workers that direct contact when administering vaccines, medical mask, eye protection, and hand hygiene, because they'll be in close proximity to the patient. Then those who are managing the crowds, outdoor crowd management, medical mask. If indoors, they should use eye protection. But if they're outdoors, they don't need to. Then PPE, measures to reduce the risk of transmission for persons receiving vaccination. Children at the age at which a country recommends mask wearing, an adolescent should wear cloth masks or medical masks. Children under 5 years of age, PPE is not required. However, they should be faced towards the mother, parent, guardian as the vaccine is administered. Adults receiving vaccination should use cloth face masks or medical masks. Injection safety. You should use safety engineered injection devices, auto-disabled syringes if you have, ideally with a sharp injury protection feature. But if it's not available, use sterile single-use syringes and needles and discard directly into the sharps box. Perform a hand hygiene before preparing your injection material. Prevent contamination of the vials by wiping the diaphragm with 70% isopropyl alcohol or ethanol on a swab or cotton wool before piercing the vial and allow it to dry. Label your multi-dose vials with a date if it was just used, and discard as recommended. Use a fresh needle each time to pierce the diaphragm after cleaning with 70% alcohol. If it's not a pre-filled vaccine, do not reuse needles or leave a needle in the diaphragm for reuse. Discard multi-dose vials immediately if sterility is questioned or compromised, or if it's not properly labeled with a date of first use. Skin preparation for vaccination. Injection is given into the deltoid muscle. Disinfect with 60 to 70% alcohol-based solutions. Ensure the alcohol is dry on the skin prior to injecting the vaccine. Clean visibly dirty skin with water before disinfecting with alcohol. Environmental cleaning and waste management. Prepare each injection in a clean designated area. Clean and disinfect the vaccination area at least twice daily with special attention paid to high-touch surfaces. Ensure sharps containers are within arm's length at site of vaccination, and then discard used syringes as a single unit into a sharps container immediately. Seal the container when 3/4 full. Store sealed containers in a designated secure location till removed for final disposal. Do not empty, open, or reuse sharps containers. So in summary, there is a potential risk for transmission of COVID-19 at vaccination sites, and we must be prepared and competent to prevent transmission. Standard precautions, hand hygiene, injection safety, environmental cleaning, waste management, transmission-based precautions, PPE with physical distancing, ventilation, and screening of patients must be performed. Clean, well-ventilated, spacious environments are to be used, and where possible, or where this is not available, do use the outdoors. It is also important to have knowledgeable and skilled healthcare workers who know what they're doing and who have been trained properly in IPC. There you also require an informed public so that they can cooperate and collaborate with you. There should be the relevant protocols and guidances which should be followed, and good logistic and supply chains to ensure that there is constant flow of the vaccines, constant flow of IPC materials, constant flow of the other consumables. So I will answer some of the questions. One of the questions was, why must I wear masks after vaccination? 2 reasons. There might be others, but these 2 are very important. What we have good evidence for is that the vaccines will protect you from severe disease. We do not yet have adequate evidence that it will prevent transmission. But we do know that data is being collected and preliminary results are promising, but do not yet suggest that transmission will be interrupted 100%. The second one is that it takes about 2 weeks after the second dose before the immune reaction is robust enough to protect you. And so till we know whether it prevents transmission, let us continue to wear our masks, especially where we are in public, so that we can protect those who are susceptible. And because of that, let as many of us go forward and get our vaccines. The other one that people seem to be bothered about is that the messenger RNA can cause genetic modifications of cells. The answer is no, it cannot. The messenger RNA codes for the spike protein, which stimulates antibody production. However, for the messenger RNA to be able to integrate into your cell DNA, it will require that, in addition to messenger RNA, that they had added reverse transcriptase enzyme as well as the integrase enzyme, because you need the reverse transcriptase to convert the RNA to DNA. And then you need integrase to allow the DNA to be integrated into the cell. And those do not exist in this vaccine. So, and furthermore, RNA is degraded over time in the cell, so it is not persistent. There's another one that came out that people have been talking about, that the Pfizer vaccine causes blood clots and so many adverse events. That is it safe? Part of the problem we're having is that things that would normally be within the scientific community are now out in the open. And unfortunately, the public do not know how to interpret the information that they're getting. When a new drug or vaccine is being evaluated on people for effectiveness, after all the safety trials have been carried out, and we know that it is efficacious, any illness or mishap that occurs after the administration of the drug in that time frame will be recorded as adverse events, including if you have a motor accident, it will be recorded. After that, and they call all of these adverse events. Now, these adverse events are certainly not all related to the virus and to the vaccine, and may not even be related at all. Then they will be evaluated by independent people to ensure that to see if they are related or they are not. I want to remind us that, so from reports so far, these clots do not appear to be related to the vaccine, but scientists continue to monitor, but to remind us that millions of doses have gone out, and there have just been a handful of reports of clots. And to also say that in the general population, there are many people who have clotting problems. So it's for something that we're giving to the whole population. Certainly, there will be random coming together of clotting and the vaccine at a certain time, not necessarily a cause and effect, but they happen to be happening at the same time. So the scientific community and WHO continue to monitor these, and but so far it does not appear that it is the clot. And WHO came out with an advisory recently, and it does appear it is quite safe if you think in terms of the large numbers that have already taken these vaccines with no problems. So thank you very much for listening. Are there any other questions?
Thank you very much, Professor Shade, for that very, very insightful presentation. I thoroughly enjoyed it myself, and I definitely have some lessons that I've learned. Thank you for that. So as part of our agenda, we will move to our next speaker, Ms. Ezine. Now that we have a good understanding, of the IPC measures, just for your knowledge, it's good to understand how well countries are doing on the continent. So Ezine will be sharing with us what the vaccine rollout looks like on the continent. Over to you, Ezine.
Thanks again, Wande, and good morning or afternoon to everyone. So we're just going to quickly look at the status of vaccine rollouts in Africa. Dr. Shade had done a very good job in explaining the different types of vaccines and how they work. And so as we're calling these names, we're no longer new to them. But to start with, I just want us to have a quick overview of vaccine approvals. And this means on the continent, who has approved what, in as much as the WHO and FDA and all that are approving vaccines, countries also have to do their due diligence to approve them. So you can see we've strategized, we've broken it down to the different platforms, like she explained how they work and the types of vaccines, and you can see the efficacies. I saw some questions on efficacies. So you can see the efficacies of the vaccines, how many doses, the intervals between doses, how they're stored. And then the last two columns are really what I want us to just look at. So you can see which countries have granted emergency use authorization after looking at the data, after looking at the vaccine, and feel that, yes, we are authorizing that this can be used in our countries. So this just let us know that countries are also doing their own due diligence in addition to what the international community says for the different vaccines. So you can see for Sinopharm, which is the one from China, has quite some numbers there. And the most is given to AstraZeneca, which has more than 10, close to 15 countries already authorized it on the continent. And that is followed by the Gamaleya, the one from Russia, which also has a very significant number of countries that has authorized it. So the last group is, you can look at the Johnson & Johnson has only been approved in South Africa, and it has 85% efficacy. Novavax also has 89 in the 80s efficacy. And all these ones we've mentioned, they can be stored in room temperature, like she mentioned. And Rwanda has approved Novavax, the only one on the continent. And Rwanda, Botswana, and Tunisia are the only ones who have approved this genetic and mRNA vaccines. And they are the ones who have to be really stored at very, very, very cold temperature. But for vaccinations, I saw this question in the Q&A. So for the vaccinations, these ones that need extreme cold temperature can actually be stored during vaccination when you've gone out to the field to vaccinate. So the The mRNA can be stored in, the Moderna one can be stored in a fridge temperature for a month. The one that is usually at -20, and the one for -80 can be stored in the fridge temperature for 5 days. So that gives you time when you're actually in the field vaccinating to be able to do your vaccination. So I hope this actually answers that question. So we'll just move into the discussion we're actually supposed to have today, which is where are we in terms of vaccine supply, in terms of vaccine administered on the continent. So on the continent, we're using AstraZeneca, we're using Moderna, we're using the Pfizer vaccine, we're using Sinopharm, we're using Sputnik V, and we're using J&J. So we're using 6 vaccines on the continent, and you can look at the map and see the breakdown of which countries are using what. So most countries, 26 countries actually, are using AstraZeneca, and that's the highest on the continent. 11 are using Sinopharm, and then 2 Sputnik V, 1 J&J. Only 1 country is using the genetic mRNA vaccines. That's Rwanda is using the Moderna and is also using the Pfizer in addition to AstraZeneca. So you can see some countries actually combining, and you can see the combinations there. Some are combining AstraZeneca and Sinopharm. Some, only Rwanda has been able to do the genetic ones and AstraZeneca. Some are combining Sinopharm and Sputnik V. Some are just using only one. So it depends on what the country decides it's best for them, and they're using both of 2 or 3 vaccines at the same time for vaccination campaigns. So on the continent, as at Monday, we have 23.6 million doses of vaccines have been supplied, not administered, just supplied to the continent. And we'll see later how many doses have been administered. So this is sort of like a more detailed breakdown of the figures, the numbers of where the vaccines have been supplied, which type of vaccines, when did they start vaccinating. So the countries in yellow, all the countries colored in either brown or yellow have received vaccine, but those in brown have started vaccinating. They started their vaccination campaigns, and the ones in yellow are yet to start vaccination campaigns. So we can actually just take a few seconds to just look at countries or neighboring countries or countries of interest to you, when they started the vaccination campaign, which vaccines are they using, what doses. So that's the information that we can get from here. And as you can see, I think the country that has gotten the most vaccines is Morocco, that has 6.5 million vaccines, and they're using Sinopharm and AstraZeneca for vaccinations. And I think that's followed by Nigeria. And then we can have, I think, DRC, Ethiopia, Kenya in the millions. So at least that gives us some picture of where we stand in terms of vaccination supply on the continent. So then we just want to look at what has been supplied vis-a-vis the population. So most countries are still below 10%. What has been supplied is still below 10% as per their population. So it's just about 10% of the population they have is vaccine that has been supplied. So the only country that has gotten up to like 60, almost 100 of the supply vis-a-vis this population in Seychelles, that has quite a significant number because they have a very smaller population. So that's that for this. So just want to mention each vaccine one by one. So like I mentioned, 26 countries have received AstraZeneca vaccine, and that is about 20 million. So AstraZeneca makes almost 80% of the vaccines received is actually AstraZeneca, and most of them are located through COVAX. That's where there is a COVAX facility that is trying to make sure that at least 20% of Africa is vaccinated. And we also have countries also receiving vaccines through bilateral engagements with either China or Russia or India. So they either buy or it's being donated. So we tag those as bilateral engagements, while we have the COVAX that is supplying majorly for now AstraZeneca. So Sinopharm, like I said, there are 11 countries that have Sinopharm: Senegal, Guinea, Zimbabwe, Mozambique, Morocco, Egypt, Algeria, Seychelles, Gabon, Equatorial Guinea, and Congo Brazzaville are using Sinopharm, which is that from China, and it's one of the whole vaccine platform group. The Sputnik V is only being used by 2 countries, Algeria and Guinea-Conakry. And Pfizer is, like I mentioned, is just Rwanda that is using Pfizer, and J&J is in South Africa, and Moderna is being used in Rwanda as well. So like I mentioned, we also looked at the type of vaccine vis-a-vis allocation mechanism. So like I mentioned, COVAX is majorly AstraZeneca, and then they've also supplied the Pfizer as a BioNTech to Rwanda, and I think 2 days ago was supplied also to Cabo Verde. So these are all the ones that are bilateral engagements with the vaccine company themselves or the country of origin of the vaccine. So these ones have their direct engagement with countries. Then looking at administration now, which countries, how much has countries administered? So you can use there are countries that have started administering, but these are the only ones we have data from. So some countries are not yet sharing data on the quantities that are being administered, why some are sharing. So with the legend, you can see countries are between 0 to 5,000 that has been vaccinated. And majority of the ones we have data on are between 5,000 to 100,000. So the only country that is crossed the million mark is, in terms of vaccination, is Morocco. And Ghana is close behind with about 300,000. The rest are between 300,000 and 100,000. So this also is giving us finite, definite figures of the vaccines, how many have countries vaccinated. Morocco, like I said, is about 5 million people using Sinopharm and AstraZeneca. Then Senegal, 68,000 Sinopharm and AstraZeneca. Ivory Coast, 8,000 using AstraZeneca. Ghana, 300,000 AstraZeneca. Angola, 34,000 AstraZeneca. South Africa is about 145 using J&J. Sinopharm is Zimbabwe using Sinopharm and 36,000. Mauritius about 16,000. Seychelles 88,000 and using Sinopharm and AstraZeneca. Rwanda using all three. 240,000. Kenya is at 4,000 with AstraZeneca. Egypt 1,100, 315 AstraZeneca and Pfizer, and 75,000 for Algeria using Sinopharm and Sputnik V. So this gives us like definite figures for what we talked about earlier. So then finally, we just want to look at priority groups. As you're aware, the vaccination is in phases, and countries have decided to prioritize key groups for the different phases. And we have the healthcare workers are being prioritized in some countries. People with comorbidities are also being prioritized for this phase 1. Elderly people 50 years and older are also being prioritized. Other frontline workers like teachers, people in security forces, dispatch riders, immigration officers are also being prioritized. And in some countries, prisoners and leaders are being prioritized as well. So you can look at, using the legend, look at where you have only healthcare workers. Almost everybody is prioritizing healthcare workers as part of their phase 1. There are 2 countries that are now, Morocco is vaccinating everyone. They've gone past the first phase and they are now vaccinating everyone. Initially, Mauritius also started vaccinating everyone, but with new lockdown measures, they've gone back to strategic vaccination to abide with the rules. So this just gives us a picture of who are the key people that are being targeted in different areas. Some places it's just only healthcare workers, while in other places it's healthcare workers in addition to other groups. So that's all from me, and open to questions if you have them. Thank you. Over to you, Wendy.
Fantastic. Thank you so much, Ezine. That was a fantastic presentation. I think it's time for us to go into the question and answer session. Today on my panel, I have experts, like I mentioned, from Africa CDC, from ICANN, US CDC, WHO EMRO, and WHO AFRO, who would be available to answer some of your questions. I see my colleagues are already typing some answers. Panelists, feel free to type some answers or indicate if you'd like to take some questions. So Prof, I think there are quite a few questions for you. One of them is around giving the vaccine. Actually, two of them is going to be a two-in-one question, if you're happy to take that. This question goes back to, it was said no glove is required for intramuscular injection. My question, however, is should the patient bleed after the IM injection? Is there a possibility of contact with the blood? Then there's another question around, does wiping the injection site with alcohol swab potentially affect the efficacy of the vaccine? So Prof, over to you.
Hello?
Hi, Prof, we can hear you.
Okay, thank you. It went silent for a while. The alcohol, when you rub the site, you should wait for it to dry and then you give the injection. It's not, it doesn't affect, and then you're not injecting on the surface of the skin. It's gone through to the, so no, it does not affect it. The other question was, why no gloves? In general, there's no bleeding, but if there is bleeding, you will see it, then you can wear your gloves. But when you are about to give the injection, you are going to hold the skin and you push in the needle and then you bring it out. So even if there's going to be any bleeding, it's on the way out and you will see it. So then you can use gloves before you apply your plaster. I don't think there's a problem. That's not a common, it's not something that's going to happen all the time anyway.
Thank you so much, Prof, for that response. My colleague from EMRO, Dr. Zaid, I see that you have answered this question, and also Prof has answered this, but I think just like Prof mentioned, sometimes some of the known things that we know in the science community goes out to the general public and it starts to cost like a frenzy. So if you'd like to share from like the WHO perspective around the blood clot cases post-vaccination has been reported across several countries. Dr. Basim, if you'd like to take that question, over to you. Dr. Zaid, are you with us? You need to unmute yourself.
Hi. Yes, Yolanda. Sorry, I was on another call. It's a busy day here at EMRO. Sorry. Yeah, could you please repeat the question again?
Yes, it was just to reiterate some of the concerns and the answers that Prof has given. And I see that you also popped in a few answers there, just to give a sort of a WHO sort of response around our concerns around blood clots related to post-vaccination. Over to you.
Yes, thanks, Yolanda. You know, this is probably the biggest immunization campaign ever. In the recent history, and we expect, of course, I mean, all the international community, we expect because of the higher number of recipients of those vaccines and also the multiple manufacturers, we expect that, and we ask actually countries and the vaccinators to report, and also the vaccinees who receive the vaccine to report all side effects around this vaccine. So we expect a huge range of side effects associated with this vaccine for several reasons. This is most of the vaccines have gone through a very rapid process of development, of course, not to compromise safety and efficacy, but this is, of course, significantly shorter development or manufacturing time frame compared to the routine or regular ones. This is number one. Number two, again, this is, as I said, a very high coverage campaign around the world. So we expect some of these things. When it comes in particular to blood clots, I think the countries that have reported this association are doing meticulous further study of whether this association is real or is of causal nature. This could be coincidence, but because it has been reported from several and different places, so the international community is doing meticulous investigation of the causality of or the real whether there is a real association between the vaccines and whether the vaccines are attributing to this phenomena to increase incidence of blood clots in some people. This is number two. Number three, I think the European Medicine Association, Medicine Agency yesterday, they reported that although there has been some reports about blood clots that might be associated with some vaccines, although they are still investigating, but still their statement yesterday confirming that still all the vaccines, all the COVID-19 vaccines benefits still weigh and still outweigh all the reported side effects around those vaccines. So we have to put that in mind that we have a pandemic that kills people, and one of the best option and best public health strategy is to get people vaccinated in order, as been said in the presentation, in order to reduce the spread and transmission of this virus and stopping the virus from killing more people and from causing morbidity among other people. So this is a quick note from my. Over to you.
Thank you very much, Dr. Basim,
Yeah.
for the response. Prof?
Yeah, and yes, I just wanted to add on to that. I also want to remind all of us that there's no risk-free strategy. There's no drug that we take today that is risk-free. Even our simple paracetamol, if you read all the adverse events that are possible, then you wouldn't take Panadol or paracetamol again. I mean, it can cause severe kidney problems, but it's a matter of probability, one, and whether you're doing it in the dosage that is required, and then two, the risk benefit. So it's really, at the end of the day, actually, taking vaccines is a choice. Am I very convinced that COVID will not kill me or kill my loved one? Are the risks of the vaccine so many? People clot all the time in the community. So we still have to find out whether, as Dr. Zaid said, is this a coincidence or is it causing it? Without vaccines, people were having clotting, they were going to hospitals for clotting. And don't forget, when we were doing this mass campaign with so many people, we're going to give vaccines to people who have clotting issues. And if they do have it, we're going to check. We wouldn't know before we give the vaccine. It's just that if they come to hospital who have a clotting issue, even who had been started before the vaccine, we're going to record it. And we have to now decide, was the vaccine the one that caused it? Or, so not everything that's coming out as adverse events are actually caused by the vaccine, but that in doing due diligence, we accumulate all the information of anything that's anything that goes wrong at the time we're giving vaccines or in the period just after the vaccines. It's part of what we do for every single drug that is developed. It's not new. And if you look at what we get from other drugs, it's always a long list. Most times it's not causal. I don't know whether this is causal or not, But if we also look at the long list of people who have had it without any issues, there will be, we expect that there will be some side effects, but it should be minimal and in very few people. I don't think we can get any vaccine that's 100% safe, or any drug for that matter. Thank you. I just wanted to really, thank you very much. Over.
Thank you, Prof. I like the fact that you've raised something that a lot of us, even as healthcare workers, always forget, is that even sort of the simplest drugs, paracetamol, have certain side effects. As with any drug, any line of treatment, there are considerable side effects. And I think the benefits of taking this vaccine definitely outweighs getting COVID-19. So this is a call to action. Should you have the opportunity, step forward and take the vaccine, keep yourself and keep your loved ones protected. So on that note, I'll move to Ezine. Ezine, you have quite a number of questions, but I think I'll try to merge some of them for the benefit of colleagues. I know that you have tried to put some answers on the Q&A box. I think some clarity, if you can sort of explain that slide where you talk about sort of short-term storage temperatures and long-term storage temperatures. And also, I think there's a question around if Johnson & Johnson vaccine is a one dose and can it boost the full immunity? So if you're happy to take that question before we move to the next round of questions. Over to you, Ezine.
Okay, so like I mentioned, okay, let me just do this. So like I had shared earlier, we have these, we have the ones that have room temperature, which is every other thing else except the
Fridge temperature.
Fridge temperature, which is everything else except, sorry, not room temperature, sorry. The fridge temperature except the genetic vaccines, they are the ones that need extreme cold chain. So these are for sort of like 3, 4, 5, 6 months storage. You can store them at fridge temperature. But if you want to, like Dr. Shade talked about, if you want to store it extensively for like 2 years, or long-term storage like that, you need to really now do cold chain, like really cold chain of maybe like minus 20 degrees Celsius for these normal fridge temperature vaccines so that they can stay viable for that long period of time. So if it's something more than 6 months, 9 months, you need to really do minus 20 degrees centigrade Celsius for these normal fridge temperature ones. But then if you're doing vaccination campaigns, I saw that question, when you're doing vaccination campaigns, of course, we don't have things that, unless you're storing in liquid nitrogen, but if you're in the field doing vaccination campaigns and you're using the Pfizer or Moderna, these can actually be at the fridge temperature. You can use ice boxes or those cooler boxes that we use for the normal vaccinations for them, because they can stay at those fridge temperature for at least 5 days for the Pfizer and even up to 1 month for the Moderna. So that sort of like explains that. So those for fridge temperature, it's fine if for about 6 months, but long term, you need to do at least minus 20. But those who actually need extreme freezing, if you're going to do vaccination campaigns, they can stay at fridge temperature for some days while you do your campaigns in the field, where definitely we may not have those facilities for extreme cold chain. And then, yes, Johnson & Johnson is just 1 dose. That's the only vaccine that is 1 dose. But right now they are conducting clinical trials to see if the efficacy can be boosted if they make it 2 doses. But at 1 dose, it has even a very significant efficacy of 85%. So that is even really good as a single dose, but they're trying to see how they can boost these just if they double the dose, if it's going to give us a better efficacy. But then there are other, like the AstraZeneca is trying to work with Sputnik, to see if they can boost their efficacy with why if you take one dose of AstraZeneca and the second one is the Sputnik V. So there are these, we're not done with vaccines yet. Even these ones that we have results for are still trying to look for ways they can boost the efficacy or be able to still be efficacious against these new variants that are coming out. So it's a continuous work in progress over one day. I think I've answered both questions.
Thanks so much, Ezine, for that. Thank you. Colleagues, please keep your questions coming. Today, we knew that we would get a lot of questions. So as you can see, we have dedicated quite a good amount of time to answer some of these questions. Now, this is going to be a bit of open. I would really want all the colleagues on the panel to let me know if they would like to answer this question. But apparently, it looks like a few of our colleagues are concerned, and I'm seeing questions around: can a COVID-19 positive patient take the vaccine? The other variations of the question is if it's asymptomatic COVID-19 versus symptomatic, are they eligible to take the vaccine? So I think I will start off with Prof, if you'd like to answer that, and I move to Elizabeth just to get a good mix of the answers. Over to you, Prof.
Question. Sorry. Can you please repeat the question? I didn't catch it.
Sure. No worries about that. I said that I'm seeing a number of variations of this question around: can a COVID-19 patient is the COVID-19 positive patient eligible to take the COVID-19 vaccines? And there are variations to the questions around if the person is symptomatic, asymptomatic, and things like that. So I really would like us to touch a bit on that during this discussion. Over to you.
Thank you. I think what I would say is that if a patient is symptomatic, you shouldn't take it, not because there's necessarily anything wrong with the vaccine, but that's not the time to go in and one, you're likely to, you're increasing the risk of those at the center. Two, your body's already reacting to the virus. So bringing a vaccine at that time is not, I mean, it's just chaotic. So I would say no. But if you've had it before and you're no longer symptomatic, and that was your first infection, there's no harm done, because then it could just be a boost to your immune system. Because if you now get it again, it's like your body says, oh, I've seen this before. And then it's almost like doing I'm just using general principles. Then it's like a boost. So, but while you're ill, I think that's a little, I don't have the scientific anything. I'm not the biggest immunologist in the world, but I think at that time, from an infection prevention control point of view, one, your body's already fighting it. So what's the vaccine at that time, I don't think is of much value. It would be better if after you've had it, sometime later down the line, you take another one, then that can act as a boost to the first one that was an infection. So it's almost like the infection is a vaccination going on, if you get what I mean. Your body's immune system is already reacting. So why, I don't see the value of another vaccine, of the vaccine doing that, because what the vaccine tends to do is mimic an infection. So you already have the real thing going on. There's no need to have a vaccine going on at that same time. It doesn't add value. Thank you. That's my take on it.
And this is Elizabeth from CDC. I fully support Prof in that. First of all, if you're symptomatic, we don't even want you in a vaccine clinic or standing in line or anything like that, or potentially exposing other people who are in line with you, exposing the healthcare worker who is giving you the vaccine. So that's one thing. If someone's symptomatic, we actually don't want them, near a healthcare worker to get a vaccine. Second thing is, it may end up being a bit of a wasted vaccine because your body is already making an immune response at the time, due to natural infection instead of getting instead of getting it from the vaccine. But there is a lot of evidence out there I wouldn't say a lot of evidence. There is evidence out there, though, that people who have had natural immunity, that people that have vaccine may actually have a more robust or a stronger antibody response than people who have had vaccine. So at least here in the US, we say that after somebody has had a COVID infection, they should hold off on getting vaccine for about up to 90 days. And then after that, they only need one single dose of vaccine. If it's a 2-dose, vaccine regimen, they only need one single dose, essentially as a booster. And that in that way, they will essentially be getting 2 doses overall, one through natural immunity and one through a follow-up vaccine. But that follow-up vaccine would actually come several months down the line after they have fully recovered. Over.
Thank you.
Thanks, Prof, and thanks, Elizabeth, for the very useful answers to this. That actually covers almost 6 questions that have been posted in the Q&A box. So I think that's very helpful. Prof, a few questions to you, because I think you mentioned this in your presentation. One is, what is the reason why the baby must face the mother during vaccination? And the second is, what are the reasons for the exclusion criteria that you mentioned? So if you can answer that before we move to the next questions. Over to you, Prof.
Okay, thank you very much. If you remember, one of the reasons you don't want someone who's symptomatic to come into this is so that you don't put the healthcare worker at risk. Now, we generally don't have babies wearing masks. We don't have a lot of evidence about their spreading the infection, but it can happen because they can get the infection and it can spread or can be transmitted through them. So if they are being held by their mother, they should face their mother because they already live in a cocoon with her. So, but rather than face the healthcare worker, in which case they're breathing and maybe crying into the face of the healthcare worker. So it's to protect the healthcare worker. That's why.
Thank you very much
yes.
for that. Thank you very much for that useful response. Colleagues, please keep your questions coming. Isn't it? This is I think this question would be for you. It's what are the considerations, or are there any necessary or appropriate logistics for vaccines in the African context? I don't know if you want to touch a bit about it. I know that many countries already have routine vaccination sort of supply chains and mechanisms, and which they are co-opting for the COVID-19 vaccinations. But if you would like to touch a bit on that, over to you, Ezine.
Okay, so like you mentioned, you're very right. This is not the best vaccination campaign that countries have been doing. Some countries have done even big responses for Ebola, for polio, for the routine vaccinations we all have. So there are already systems in place. And before a country places a request, they have to do some sort of assessments on their own to say what we have in the country with vaccine is most suitable for us. Do we have -20, -80 degree fridges? So if we do, where do we have them? Where can we use? So those are the things that influence which vaccine, based on logistics, which vaccines they can bring into the country. So it's not just we close our eyes and pick one vaccine. They have to do an assessment to make sure that when these vaccines come, we are able to administer them and we're able to keep them viable. We're able to transport them to the different locations and they still stay viable, and we can give them appropriately. So these are the decisions that are taken before countries decide. So there is even a question around, why are countries using more than one vaccine? Why are they using 2 vaccines? So you've done your assessments and you've decided these are the 2 that will work for you based on how your systems or what's obtainable where you are in your country, and you've decided that these are the ones that will work best for you, so you get both. And you're also looking at cost as well. So those are the issues that go into those discussions. So logistics plays a big part, because you need to make sure that the vaccine, from when you get it to when it gets to the person's skin system, it's kept viable. and it doesn't go and it doesn't get spoiled or become not viable by that time. So logistics plays a key part, and this is done by country to country basis. Over.
Thanks a lot, Ezine, for that. I did see a question that I was going to pose up to you, but I can't find it. So I'm going to move to the next one that I can see right in my eyesight. To my colleagues on the call, I know that there have been concerns around the new variant and variants of concerns that we are seeing across several countries, Brazil, the United Kingdom, and South Africa, and I believe very recently Philippines, if I'm correct. So I think this question is around efficacy of the vaccine for some of these variants of concern. I know that several countries have reconsidered sort of their strategy or the particular vaccines they will be using based on this. So the floor is open to any of my panelists who would like to take a stab at this before we move to the next round. Prof, do you want to take it up, isn't it?
I actually didn't hear. I was busy typing answers into the Q&A. I didn't. I'm
no
sorry.
worries. I'm happy to repeat it. It's just around efficacy of vaccines for the variants of concern. So I really like this to be like an open response from the panelists. So Basim, Elizabeth, Prof, feel free to jump in.
I don't have all, I can't remember, I can't remember everything, but I do know that some of the variants are showing some impact on the vaccines. And I think the South African variant was one of them. And that's why, and I think it has an impact on the AstraZeneca, if I'm right. I'm not sure, I can't remember for sure. So let me not mention any particular one. But it seems to be sensitive to the Johnson & Johnson, and that's probably why the South Africans are using the Johnson & Johnson vaccine. I think there's another one from Brazil that seems to have some impact, but I don't have the details at my fingertips right now. I don't know if Elizabeth or somebody from Afro or CDC want to answer those.
Yeah, thanks, Prof. I'm not an immunologist and definitely do not want to say the wrong thing about which vaccine might or might not be useful against which variant. That being said, though, I am glad that somebody's brought up these variants of concern, because I think it means that even though we have vaccine on the continent, we still have to double down on all the basic measures. You know, that vaccine is not the be all and end all right now. It still has to get to the basic measures of social distancing, of wearing masks, making sure that you're wearing the proper mask. You know, a single layer of cloth mask is good, but you can do better. You can have 2 layers of cloth, or even 3 layers of cloth or 2 layers of cloth with a filter in between. And we need to make sure we're doing our hand washing with all of these variants of concern, because some of them do seem to have a higher mortality rate, and they seem to be more easily transmitted. And in that case, we really have to get back to what we've been saying for the past year, and get back to all the tried and true measures of trying to stop the spread of this virus while we're still trying to figure out the vaccine issues. Over.
Just to add on to that, for sure, some of these variants are showing that that they are less responsive to the vaccine, but there's no variant yet that is totally, that totally eludes the vaccines. But if they're already showing that, the assumption is that over time we may get more changes that can make them less responsive. So as Elizabeth said, we still need to do this. The good thing is severe disease will be averted, but it doesn't mean you can't catch COVID. So I think for now, we should please just continue, and in addition, continue to monitor the variants. There's a lot of work to do. It's a very new virus. I mean, I just want to remind all of us that we've gone a long way. This is just a year plus since COVID-19 hit the scenes. It feels like 20 years, but so much has been achieved, and there is a lot to, that I think that we need to laud the scientific community about. So much has been done and so much achieved, but there's still work to be done. And I know people are getting tired. I mean, in Nigeria, it's very hard to believe that there's COVID-19. I mean, a lot of people just don't wear their masks anymore. But we keep continuing to encourage them.
Fantastic.
I just want to say a couple of things in the area of the vaccine, saying that when these vaccines were being developed, we didn't have the variants. I mean, we haven't yet discovered these new variants. And so the early vaccines like the Pfizer, the Moderna, really weren't tried. The clinical trials did not include people or include the new variants population. So now they're going back to look at how to see if it's effective. There are now clinical trials just targeted at the new variants, even the same issue with AstraZeneca. So they had to do clinical trials again to check if it's responsive to the new variant. And now they're actually, based on their feedback, trying to work on the vaccine again to develop a jab that is specific to these new variants, and they can have better efficacy against the new variant. So like Prof said, it's still a work in progress. We're just 1 year and we've discovered 3, 4, 5 key new variants, and that means we'll keep discovering. And the vaccine, it's what viruses do, they mutate. So we keep discovering, and these vaccine companies and even the newer vaccines that are coming up will now take these new variants into consideration when they're doing clinical trials, when they're developing the vaccines and all. So it's a continuous thing. And of course, countries are now doing genomic sequencing to be sure. It's part of that assessment they do before they decide which vaccine they will pick, to know which variants is more where they are. Is the vaccine you're deciding on going to be efficacious or effective against this variant? So genomic sequencing has become part of the routine surveillance that most countries are doing, even in Africa, and that helps countries also to make the decision as to vis-a-vis variants of concern. Does this vaccine work for us or not? Over.
Thanks, Ezine. So I think one final question just before we go, and before we wrap up, I'll also give all the panelists an opportunity to say just one line, if you can, so start thinking about it. If you had to advocate or say anything about vaccines, I think it's important that we leave our participants with a resounding message around COVID-19 vaccination and how to keep ourselves safe. So I'll come back to that. But I will throw this question because I just saw Prof. Valerie now. It's around IPC, again, going back to vaccinations. IPC approach for vaccinations with Ebola and COVID. Are they the same or different? And if they're the same, does this mean that countries that have experienced Ebola in the past have some sort of advantage? I think we just need to reemphasize sort of the necessary IPC approaches for vaccination against Ebola and COVID-19. Over to you, Prof.
Okay, so I'm from Southern Africa, so I have not worked in West Africa. But we have to remember our IPC practices are based on the mode of transmission of a pathogen. So when we're talking about COVID-19, we're talking about respiratory transmission, droplet transmission, and contact transmission. When we're talking about Ebola, we're talking about contact transmission. So the type of PPE you need for COVID-19 is not as extensive as you need for Ebola. So the approach is different, but if you consider basic IPC principles based on transmission, then you come up with the correct solution. And Prof. Gorgonzola talked about the PPE requirements for COVID-19 very clearly. And I think you didn't hear any mention of hazmat suits at all in her presentation. And I think that perhaps describes the difference between the two.
Thanks a lot, Prof. Val. That's very useful. It's good for us to also remember that, the PPE required for both infections. So on that note, I think we've had an exciting Q&A session. It's been quite eye-opening, and I would like to hand over to Prof. If you could say one thing to our colleagues on the line about vaccination, what would it be? And right after Elizabeth, Ezine, Prof. Val, and Zaid. Over to you, Prof.
Thank you. Let me remind everybody that the fact that these vaccines came out early does not mean that there was a shortcut in terms of checking them for safety. One of the things we must realize is that COVID-19 is so infectious. There were lots of people that we could test, so that they could carry out their tests in a much shorter time and get the numbers very quickly. At the end of the day, there is no perfect solution, but the vaccines are generally safe. There will be some with side effects in people, but I would advise everybody, please do go take your vaccines. Most people that have taken these vaccines, and I mean the overwhelming majority, have not had any major side effects, just a few inflammatory things and pain at the site. And those are things that we're used to. Thank you.
Thanks, Prof. Elizabeth?
Sure. For me, I think of two things, one of which is I would much rather deal with a side effect of vaccine than I would want to deal with actually being infected with COVID. You know, if I look at my two choices, I think the vaccine is clearly the better way to go. The second is vaccines have been proven time and again critical and important and fundamental to the way that societies can flourish and improve. And we just have to look at how smallpox has been eradicated, how polio has been largely controlled, how measles can be controlled with good vaccines. Think about all the childhood diseases that have largely been controlled, not 100%, but largely been controlled with vaccines. And I think we need it. I think the big difference with this is that suddenly we're saying that all adults should get vaccine, but we're used to saying all children should get vaccine and all children should get multiple vaccines. I think it's time for all of us as adults to also step up and also get vaccines to try to get rid of this bug in the world. Over.
Is it my turn?
Yeah.
Sorry. As soon as I am eligible for a vaccine, and in Zimbabwe, where, as you saw, vaccinating healthcare workers, frontline workers, as soon as I'm eligible, I will be there to get my Sinopharm shot. I recommend everyone else does as well, gets vaccinated.
Thank you. Ezine?
Everyone has said it all, just in case anyone is still sitting on the fence as a healthcare worker, because actually a lot of healthcare workers are very hesitant, even with all the knowledge we have, but it's understandable. This is all new to us, but just in case you're still sitting on the fence, I really hope all the conversation we've had today, very sincere, candid conversation, has helped a bit to help you edge towards whenever you're available or whenever the vaccine is available where you are, that you take the vaccine, because I will, once it gets to where I am, definitely take the vaccine. Over.
Thank you. Basim?
Yes, in my opinion, I think let's get the vaccine. The best COVID-19 vaccine I would recommend is the one available to you. There isn't much, in my opinion, there isn't much significant differences between the different types of available registered vaccines, COVID-19 vaccines. So the best one is the one available to you. This is number one. Number two, it will take time, unfortunately. We would appreciate if we could have a huge number of vaccines available by now, but it may take time for majority of people to get vaccinated. So we still need to continue, unfortunately, or fortunately, depends on how you see it. We still need to continue practicing the COVID-19 protection bundle, if you will. We need still to continue with the masks and distance and physical distancing and hand hygiene and other protective measures while we are in crowded places. And also we have to monitor and we have to protect ourselves. We have to still conduct screening and triaging in healthcare facilities and in the public places and public buildings as well. Um, um, Unfortunately, this may take some time, as being said by other colleagues, till we reach a critical point or a threshold where this virus will find less susceptible people in the community being vaccinated, so that it can slow its transmission. But on the other hand, compared to other outbreaks and pandemics, this is really quick and fast. The response of the 21st century is significantly better, in my opinion, compared to other outbreaks and pandemics that the world witnessed over the last centuries. So we keep to be optimistic, take the vaccine, still continue and taking the protective measures till the immunity build up in our community, and we combat together this virus and this pandemic. Over to you.
Thank you, everyone. We've gone a few minutes over time, but we can all agree that it's been such an interesting discussion. I wish we could continue, but we would need to drop off now. I will leave you with just a few messages. Go get the vaccine. When you do, as healthcare workers, we are sort of the examples the community look up to. Put it everywhere. Show people that it's safe and it's effective. Make sure you tag us on social media when you do collect your vaccine. But in the time being, maintain physical distance, keep your face mask on, and keep your hands clean, washing them or using alcohol-based hand rubs. Thank you very much to my very amazing panelists. This was so exciting. Thank you so much. And thank you to everyone for joining in. On that note, I say bye-bye and have a lovely, lovely week. We'll see you next week. Bye.
Bye-bye.
Hi, thank you.